that in 1/3 of these patients there were actually antibodies against the neuromuscular junction. These patients were mostly mild with a good outcome. And now there is an ongoing Italian multicenter study that we are coordinating, in which basically we confirm this data in samples from more than 400 patients, in which we found mostly clustered SHR antibodies. Another advance is now the availability of a commercial biochip. So it's a commercial fixed cell-based assay in which cells are fixed. They are not live, but they still express the antigen in the native conformation. So in general, it was shown from several comparative studies that the performance is very good. There is a gain comparing to the radioimmune assay. And there is also a good concordance with the results between this assay and the live cell-based assay. The live cell-based assay have a better performance, but also the fixed performs quite well. So it could be used as an alternative to first-line standard assay. This is a study from China on more than 2,000 patients recruited prospectively. They showed how this commercial assay performed very well comparing to radioimmune assay and ELISA, especially for masked antibodies, but also for SHR antibodies. And so what is the place of cell-based assay in the clinical practice? They could actually replace first-line standard assay because of their high diagnostic accuracy, the ease of implementation. They have some benefits also comparing to radioimmune assay because there is no need for radioactive reagents, while live cell-based assay has a better performance but should be reserved to patients as a second-line testing alternative. And actually, the use of cell-based assay has been proposed and suggested by different guidelines internationally, from the Italian one, the Japan one, the UK one, the German one, but also for the international one, especially for the case of seronegative myasthenia gravis, because it can change their antibody results, and this has bigger implication for the therapy. What are these therapeutic implications? We now know that patients that are positive for SHR antibodies are candidates for complement inhibitors and for FcRn blockers. So it's important to detect these antibodies because we give an additional occasion to these patients to have access to these treatments. It's also important that patients are tested for masked antibodies with the up-to-date diagnostic assays, because these patients might benefit from rituximab or some FcRn blockers. And in seronegative MG, it's important that we perform all the available antibody testing in order to choose the treatment, but also do a more specific differential diagnostic pathway for these patients. Before concluding, I want to show you the news related to the therapy in which we use basically the mechanism of action of these antibodies as a target. For example, this is a study that has been published very, very recently, in which an IgG and IgM protease could disarm SHR antibodies by cleaving the Fc gamma domain. So basically, there was a specific removal of only SHR IgG from NG sera, and also not only SHR IgG, but also SHR IgM. In fact, in a proportion of patients included in this cohort, there were patients who had both SHR IgG and IgM. They showed that also SHR IgM could activate complement in a better way, in a more efficient way than SHR IgG. And so it was important to deplete both these isotypes and not only SHR IgG. And this is a very important approach, a combinational approach based on the isotype-specific antibodies. Another interesting approach is the use of soluble SHR-Fc that they can act as antibody trap. They basically, as shown before, the target only SHR antibodies. They can induce ADCC, improve symptoms also in mice model. There was also a similar therapy studied for MuSK-MG, so MuSK-FC fusion, that could bind and neutralize only MuSK antibodies, could restore the MuSK signaling. And there was also some demonstration in which there was a tolerance restoring. So this antigen-specific immodulation without a general immunosuppression, which is the current therapeutic approach, has potential also for restoring tolerance and so for basically stop the disease course. And finally, for MuSK antibodies, for the blocking of MuSK antibodies, there were also these papers that have been published very recently about the use of this MuSK agonism. Basically, the first study was done on mice models, so MuSK-MG mouse models, in which basically these mice were injected with this bivalent MuSK agonist, and it was seen that there was basically a restoring of MuSK phosphorylation, SHR clustering, and preserving of the NMJ architecture. Subsequently, the same agonist was basically used in passive transfer models, in which mice were injected with MuSK IgG4 from MuSK patients. Unfortunately, only in one patient there was a restoring of MuSK phosphorylation and the NMJ architecture. This limited success was probably due to the level of the MuSK agonist was injected in these patients. So the non-responders had a higher level of MuSK antibodies comparing to the MuSK agonist that was injected. But in this study was interesting also because it was proposed to use a functional assay of SHR clustering rescue that could basically predict the action of MuSK antibodies that could be used to stratify patients who could respond very well to this treatment. So the therapeutic efficacy was patient-specific and require a selection based on these functional assays. So to conclude, we saw that SHR, MuSK, LRP4, myasthenia rely on different effector mechanisms. We saw that it's more complex than we thought. It's not only the titer that counts, but also the IgG subtype, the antibody isoform, the affinity maturation, and how they act when they act in a combined manner. So there is a shift from antibody, yes or no, present or non-present, and to what antibody, how it acts, what is the mechanism of action, what are their characteristics. Cell-based assay have transformed the serological diagnosis of MG. The performance is increased. Now we know that patients with seronegative myasthenia gravis have to be tested with this assay to be sure that they are really seronegative. These diagnostic assays that should be integrated with functional assays in future so that we can stratify patients not only from the diagnostic point of view, but also from the prognostic point of view and for the therapeutic decision making, because the antibody subtype now can guide the treatment choice. So we are basically experiencing a paradigm shift. We treat the antibody mechanism and not the whole immune system anymore, which is a great advance in myasthenia gravis. Thank you for your attention.
Thank you very much for this exciting news and very clear exposition. I'm glad that after almost my lifetime as a professional, we finally are smashing the cases of seronegativity, which apparently is just a new name for our ignorance, which is not a new thing, but it's good that we see that now we have infinite opportunities to expand our knowledge and treat our patients. So there is Satya Dudu, he has a question. If he wants, he can unmute himself, and while he does it, I'll read what's on the written part. So low complement levels is more in line with severity of disease than antibody titers. And that's a question for you, Valentina.
Yes, absolutely. So the antibody titers basically has been shown that do not really correlate with the capacity of the antibodies to activate complement. Is more related to the subtype, the prevalent subtype, and probably also the isotype, the isoform, as we saw that from our preliminary data, there is a correlation between binding to the fetal or adult isoform of the antibodies and the capacity of activate complement. So we don't have to look at the titer, we have to look at the function of these antibodies.
Yeah, that was very clear. And as there is, I don't know if Satya has any additional comments. If not,
just one. Yeah, that's great. Thank you very much for the great lecture, and it's very useful. And one more question: how sensitive is the single fiber EMG in your practice in seronegative myasthenia gravis? How useful you find it, please?
That's a very good question, very interesting question. It is highly useful. So I didn't have the time to talk about the neurophysiological studies, but they have a central part in the diagnostic pathway of seronegative myasthenia. First of all, because we don't always have the antibody results immediately in patients. So it is a great help, and for especially for ocular myasthenia gravis, in which seronegative patients are quite prevalent, it's important to also perform single fiber EMG. We are now working on patients prospectively recruited with diplopia ptosis, and we saw that single fiber EMG was strictly correlated with the final diagnosis of MG, even in a subset of patients who didn't harbor any antibody. So definitely a test that should be used. A bit the correspondence of the CBA, but from the neurophysiological side.
Yeah. So do you think that's highly do you have a number for percent, like 80%, 90%, or 60% roughly?
So from our data, it was a population of 115 patients. In the end, we diagnosed 40% of patients based on the single fiber, with exclusively ocular symptoms. So it is quite a relevant proportion.
So you'd call it as 40%, yeah. Okay.
Yeah.
Okay. All right. Yeah. Thank you very much. Thanks.
See you.
So I don't see any other questions in the chat, but I will advance with some of my own, if you don't mind. So to begin easy, in the beginning, you started explaining asking for antibodies, and we still do it very much as a routine, as you know. And in the past, they even told us to first ask for AChR antibodies, and then if they come negative, ask for the mask, and the LRP4 was not even talked about. So what are the new paradigm to ask for antibodies? Can I ask for all of them and to speed up the process? And if it still is apparently seronegative, then can I bug people to have the CBAs?
So that's a very important question because, I mean, I didn't have the time to go into details, but from the table I show you from the guidelines internationally, there are still some guidelines that suggest to do a subsequential antibody testing, start from AChR and then mask, and then eventually pass and do the CBA. But if we're really going to shift and just use the CBA, actually the commercial fixed CBA that is now available provide provide a detection of AChR and masked antibodies with only one test. So this subsequent need for analysis is basically surpassed in this case. With only one test, we can test at the same time for all these antibodies, which is an advance, in my opinion.
And probably shortens time for diagnosis as well.
Sir, can I have one more question, please?
Yeah, please.
Yeah. So, how many of the seronegative ones you found it to be congenital myasthenia or anything, or is it too rare, or how many of the seronegative ones you found them to be congenital myasthenia? How have you found any of them seronegative to be congenital myasthenia?
You mean by using the CBA?
Or like if you because they are single fiber positive, but they are not autoimmune, but they turned out to be congenital myasthenic. Yeah.
So of these 40 patients, of these 40% of patients, there were in our court around 10% of them without antibodies in the end, so seronegative.
Okay, so you think that you suspect they are 10% are congenital myasthenic one rather than autoimmune one?
Now, I think they have an autoimmune condition
All
because
right.
then they were treated and they respond very well to immunotherapy.
Okay, all right. Yeah, right. Thank you. Okay.
Coming back to the pre-CBR world, what do I do if I get a low titer for HCHR antibodies and even mask antibodies? So shall I stop there? What do I do next?
It depends on the test because for ELISA, definitely antibodies with the low titer should be retested. We saw that they don't have a good performance both on the sensitivity and the specificity side. It is not a very performing test, although it's used as a first line in many countries. So definitely go for a CBA in these cases. Radioimmunoassay is more reliable. I would say in this case, you could also wait and retest the patients, especially if it was tested at the onset. Some patients are seronegative at the onset and then they seroconvert later. So definitely trust more the radioimmunoassay than the ELISA in this context.
Very good. I don't know if Sati or someone else still has questions, so please manifest yourself. If needed, I can unmute other people.
No, I am done with my questions. Thank you.
Thank you for your participation, Sati. So thank you very much, Valentina. This was a very instructive session, and it was a glimpse into the future of myasthenia gravis treatment. And I think now that we are being invaded, hopefully, with new treatments, it's good that we start by understanding why we prescribe them and how we choose them. And I think you were very helpful in that sense. Thank you very much. And
thanks to you for the invitation.
Thank you. Hope to see everybody in the next session of this Neuromuscular Junction series. Please leave your feedback on the form. There is a link on the chat for you to do it if you want. And thank you very much for attending. Bye-bye.
Bye. Thank you.
Bye. Thank you.